Most of the discussion will take place in English. One of our panelists will be addressing you in Russian, and I'm told number one in your headsets is English, number two is Russian. As you know, as we gather in Vienna today, we face a very significant challenge with regards to the global response against HIV and AIDS. 2010 was the deadline for universal access, and I think that it doesn't escape anybody the fact that we are nowhere near from delivering on the pledge of universal access. This was a commitment of the G8. The G8 has not delivered on that commitment, and they have really not explained to us what the next steps are going to be to correct this gap. This is a very serious deficit, both at a moral level, if you want, for the lack of delivery on a pledge, a long-standing pledge, but also at the humanitarian level because of the implications that this has for the 10 million people in the southern of the world that are in need of treatment. Let's rejoice in the fact that today we have treatments that work. We have shown that this can be done. We have over 5 million people on treatment, and therefore what we need is the political will to go the extra mile to deliver on universal access. But this is not just a humanitarian pledge. Data that was published from our group in particular earlier today in The Lancet will show that the more we treat, the more we prevent. And this is not just because it's biology 101. When you put somebody on treatment, you render them almost unable to transmit as long as they are appropriately treated. So data that was published earlier last month in The Lancet showed that in the heterosexual context, for example, there is a 90% reduction of HIV transmission when the infected member of the couple is on treatment. You also know that WHO and UNAIDS have called for elimination of mother or parental transmission of HIV, as we said earlier today, with the use of antiretroviral therapy. This can be 100% effective. So if we're not doing it, it's because we don't want to do it. But this is an urgent need, both because we need to do the right thing, but also the smart thing. We need to invest on health to make things happen. And at this conference, you will hear more, and I'm not going to take the thunder away from him, about Michel Sidibe's new initiative on behalf of UNAIDS to wrap up this notion of treatment as prevention and treatment simplification as part of the prevention revolution, which we hope will become one of the most significant emerging themes of this conference, over and above the human rights issue, which I'm sure Brigitte is going to address in more detail. So from my perspective, we have a serious problem with the political leadership globally, and we're here to fix it. Thank you. I'm going to move on to introduce my co-chair, Brigitte Schmidt. She is the 2010 local co-chair. She is the president of the Austrian AIDS Society and has the HIV department and outpatient clinic at the Otto Wagner Hospital in Vienna. Brigitte has been involved in issues related to HIV for a very long time, including HIV in pregnancy, elimination of HIV transmission in that setting, post-exposure prophylaxis, and in fact, she pioneered the immediate initiation of antiretroviral therapy for post-exposure prophylaxis and propagated its implementation throughout Austria. Brigitte.
Thank you, Julio. Good afternoon, and a very warm welcome to the 18th International AIDS Conference and to Vienna. Vienna was chosen to host the conference because it is a crossroads between East and West, and the HIV epidemic in Eastern Europe and Central Asia is experiencing the fastest growing epidemic worldwide. In Austria, antiretroviral treatment is available for everyone, and there are, of course, some other countries where the situation is quite similar. In those countries, HIV is a chronic disease, but there are many countries where the situation is completely different. For example, in Eastern Europe and Central Asia, just 23% of patients who are in need of treatment also have access to treatment. And globally, in 2008, more than 10 million people living with HIV didn't have access to antiretroviral treatment. So people in many countries, people are dying because of AIDS, and those who are on treatment very often nowadays can't continue with treatment due to shortages. In those same areas, including one of the most heavily affected regions of South Africa, funding shortfalls result in rationed care, and very often physicians and nurses have to decide who is allowed to continue with treatment and who not. So they have the decision to do who is allowed to live and who will die. Additionally, AIDS was never just about science. It has always been also about social justice. The AIDS 2010 theme of Rights Here, Rights Now reflects the importance of human rights and focuses on the importance of scale-up of HIV programs, including the right to a life free of stigma and discrimination. And the theme also emphasizes on the right to health care, including access to scientifically proven HIV prevention programs, such as opioid substitution treatment and needle and syringe programs. It is important to treat the patients, not to prosecute them. Over the past 7 years in particular, it has been demonstrated that effective treatment can be brought to scale, and we have learned that an effective antiretroviral treatment also reduces the risk of transmitting HIV. And with regard to prevention, we know that a combination of behavioral and biomedical strategies is most effective. We have to repeal laws that criminalize homosexuality and addiction, and we have to empower and educate the people, especially young women and girls. The recent progress in scaling up HIV prevention, treatment, care and support has been remarkable. And in the past 5 years alone, the availability of art in the middle and low income countries has increased tenfold to 5 million people. So just 10 years after Durban, we have shown the skeptics that universal access is achievable. That is the goal we can and we have to reach. Thank you.
Thank you, Richard. Next, I'm going to introduce to you Vladimir Jovtak. He's the president of the East European and Central Asia Union of People Living with HIV and chair of the Coordination Council of All Ukrainian Network of PLWH. He's a well-known and respected leader in the HIV community in Eastern Europe and Central Asia and has been openly living with HIV since 2000. Vladimir.
Thank you. Мы привыкли видеть другую карту распространенности ВИЧ-инфекции в мире. Сегодня мы представляем вам новую карту, карту темпов роста эпидемии ВИЧ-СПИД, где регион Восточной Европы и Центральной Азии демонстрирует самые высокие темпы распространения эпидемии ВИЧ в мире. Тема конференции «Права человека здесь и сейчас» крайне важна для людей, которые работают в наших организациях и живут в 18 странах нашего региона. Потому что именно у нас, в Восточной Европе и Центральной Азии, нарушается право на жизнь, и мы умираем. Каждый второй ВИЧ-позитивный человек в нашем регионе умирает от туберкулеза. Гепатит С угрожает жизням миллионов ВИЧ-позитивных людей. Уже сейчас в лечении нуждаются 3 больше, чем его получают. Наши права нарушаются, и мы умираем. Из-за нехватки антиретровирусного лечения, как это происходит в России и в Украине, из-за закрытия сайтов заместительной терапии, как это произошло в Узбекистане, из-за репрессивной наркополитики, при которой каждый 4-й ВИЧ-позитивный в нашем регионе сейчас находится в тюрьме, из-за коррупции в государственных закупках антиретровирусных препаратов, когда матери отдают свою терапию детям, потому что на всех не хватает. Мы верим, что конференция привлечет особое внимание политических лидеров и доноров к специфике нашего региона. Мы верим, что конференция позволит рационально использовать ресурсы, выделяемые из национальных бюджетов. Мы верим, что президенты и премьер-министры в наших странах возьмут на себя ответственность за будущее наших стран. Мы знаем, что конференция даст возможность показать успехи региона Восточной Европы и Центральной Азии в достижении целей универсального доступа, вдохновить доноров и мировых лидеров, продолжить оказывать финансовую поддержку программ по преодолению ВИЧ-СПИДа. А мы, люди, живущие с ВИЧ, отдадим все свои силы, знания, а если понадобится и жизни, чтобы остановить эпидемию. Thank you.
Thank you, Vladimir. Next, I'll introduce to you Sasha Volynina, the director of FECHA, a self-support group she co-founded. Her first mass media and public speaking experience was in late 2003 when she participated in Right for Life, a program coordinated by FECHA. At the time, she was forced to make her presentation wearing a mask to avoid hostility and discrimination. Sasha.
Thank you very much, and good evening. And well, this conference is devoted to human rights protection, and this issue is crucial for our region, because, well, as a key right, the right for treatment, the right for life is broken now. In our region, several years ago, the epidemic was silenced, and there was no treatment at all. Treatment wasn't affordable. But we managed to get treatment for 100,000 people, and the epidemic was recognized officially that it exists. But now, despite all governmental declarations, we constantly have shortages of ARV treatment in Russia. People don't have treatment, those who need it. People have to interrupt treatment, those who were on it, and people start to die in Russia again. This fact is not recognized officially. We have to prove it. We have to shout about that. But still our efforts are not heard and officials ignore that fact. Russia's position itself as a donor and constantly refuses from the money of the Global Fund. And it's a lie that we don't need help. And until government lie that we have treatment, until the problem will not be recognized, the problem wouldn't be solved, and we still be dying. Until Russia pretends that we do not have drug use epidemic, we couldn't solve this issue also. Until the Russia doesn't recognize we don't have any access to the drug dependence treatment, people will get in prison and will still die from the drug use. Until Russia pretends that there is no sex in our country, as it was in the former Soviet Union, they will spend plenty of money on abstinence and morality development instead of implementing evidence-based programs. If there's no sex, there's no any need in sexual education and prevention. And that means that people will get infected through sexual transmission. And it is proven that the first crucial step to tackle every problem is just to recognize it. Thank you very much.
Thank you, Sasha. Let me take the prerogative of the chair to bring to your attention the fact that there is a Vienna Declaration that is being put forward by the IAS and the conference as the official declaration of this conference that is addressing exactly what Sasha is referring to. In other words, we need to stop the futile war on drugs and replace it with evidence-based decision-making. We'll be happy to discuss that further with you during question period. Next, I'm going to introduce Rachel Arini, who is an active youth advocate for Indonesia. She founded the Independent Youth Alliance, the only youth-led organization focused on sexual and reproductive health and rights in Indonesia, which works to promote the right of marginalized young people. She also works with the
Greeting to everyone. Good evening. My name is Rachel. I am 21 years old, and I carry the voice of all young people who attend the conference and beyond. I come from Indonesia. It's the largest Muslim population in the world. I come from a fundamentalist religious background, and I understand what it means to be a young woman in today's world. I have friends who have been raped, married off at a very early age, and infected by HIV. Some of these things happened to me, and I was not supported to demand justice. Like many other young people, I live in an era when we are supposed to benefit from the universal access and ICPD action agenda. But sadly, young people's lives still remain challenged by poverty, inequality, and violence. These factors make us the most vulnerable to HIV. We know that the face of HIV today is young, often young women and girls, poor and marginalized. In 2008, young people accounted for around 40% of new infections, but we don't account for 40% of budgets and programs. That's why I want to highlight 3 main points in terms of young people agenda. The first is that we need to fully acknowledge and protect the human rights of young people. It's always sexy to say that you work with young people, but we know the truth. It's still hard to acknowledge, accept, and celebrate that young people are entitled to all human rights, including accepting our diversity and understanding the complexity of our identity. Identity is complex. Young people are more than just number in epidemiology. We need to avoid labeling. We must respect the diversity of young people. Young IDUs, young people living with HIV, young sex workers, young LGBT, and young women and girls. The second area is access to information and services. When I was 15, my teacher came and then told us that condom is only a propaganda to make people lose faith in God. No girls could ask questions because they said only boys were at risk. This was my sexual education. Yet I was refused by the clinics when I went to HIV testing. They say I was too young, but I know that I'm not too young to die for HIV/AIDS. I realized that what's written on paper, even international agreements, can be useless. We can do better than this. And then the third area is to invest on sustaining youth leadership. We just need to be recognized, respected, and supported, as most of youth-led networks are volunteer and informal. So, sadly, we almost have no funding for operational costs. As with any HIV programs, we have to acknowledge that one size will not fit for all, but today's donor architecture often only recognize one size fit for all. We call for more sustainable funding, which includes organizational development and core funding. And then we need intergenerational approaches that foster transparency, accountability, and support of our networks. We need equal partnerships and not just jargon. My peers and I will not only be the leaders of tomorrow, we are the leaders for today. We intend to work together for rights here, right now, and for all. Thank you.
Thank you, Rachel. Next, I'm going to introduce our first plenary speaker this evening, Dr. Yves Souterrain, who has served as the coordinator of the Strategic Information Unit in the World Health Organization's HIV/AIDS Department since 2004. Dr. Souterrain previously worked at the French Ministry of Health as a researcher in charge of implementing research programs in public health and health systems research. His plenary address is entitled State of the Epidemic, Epidemiology, Progress, Challenges, and Human Rights Implications. Yves.
Thank you, Julio. I will start first by giving some good news on the front of the epidemic. And the good news are some efforts to scaling up HIV response has brought real results. For example, prevalence is decreasing in young people in many countries with generalized epidemic. We know also that prevention of mother-to-child transmission, which is increasing, and the coverage of mother is increasing every year, has averted something like 200,000 infection in children in a couple of years. And we know also that deaths from HIV declined from 2.2 million in 2004 to 2 million in 2008, and this is largely due to treatment scale-up. The treatment figures about in 2009 will be released tomorrow. But it is possible that we have done the easiest part of the job. HIV has not only led to 2.7 million new infections in 2008, but it continues to spread fast among most at-risk groups, injecting drug users, migrants, sex workers, prisoners, and others who are often marginalized, stigmatized, and discriminated against. We know that this is happening both in countries with generalized and concentrated epidemics. We have no good data from generalized epidemic, who shows that this population, including MSM and IDUs, is also very affected in these countries. Human rights violations make it much more difficult to reach these groups with HIV prevention, treatment, and care services. This is, of course, very relevant for this conference opening today, looking at HIV globally, but also in Eastern Europe, where HIV is largely driven by injecting drug users, one of the most at-risk populations. Human rights violations affect HIV epidemiology in different ways. Let me take just two of them. First, human rights abuses continue to blind our knowledge of the epidemic. Despite some progress, epidemiology on most at-risk population groups is still limited due to various legal, social, and cultural barriers. And second, even in situations where we have sufficient epidemiological data and knowledge, failure to act based on epidemiological evidence, as it is the case in many countries, or even worse, use of the EP evidence to criminalize behaviors much worsen the situation, leading to further spread of the epidemic. So just to conclude now, we must acknowledge that human rights violations are not the only contributor to an expanding epidemic, and that human rights protection alone will not end AIDS. But it is also true that universal access cannot be achieved without human rights concern taking the central stage of the global response to HIV/AIDS.
Thank you, Eve. Our next plenary speaker, Ms. Paula Akuhisiwe, is the Advocacy Coordinator at the AIDS and Rights Alliance for Southern Africa, ARASA. ARASA conducts training and advocacy in the Southern African region to advance a human rights-based response to health and to improve access to quality of TB and HIV services. She previously worked as a procurement analyst at the Clinton HIV/AIDS Initiative in Rwanda, coordinating supply of second-line and pediatric antiretrovirals to Rwanda and Burundi. Paula will be talking during her plenary on the issue of human rights and the HIV response. Paula.
Thank you, Julia. I spoke at the International AIDS Society conference in Cape Town last year about human rights and HIV, and somebody asked me, we know what science has contributed to the HIV response. It's given us diagnostics, it's given us drugs. What have human rights contributed? And I stammered and struggled to answer the question at the time, not because it's a difficult question, but because sometimes it's most difficult to articulate things that seem so intuitively obvious. And here we are a year later at the International AIDS Conference, whose theme is Rights Here, Right Now. And a lot of you might be wondering the same thing. You've heard about human rights repeatedly, speaker after speaker. What does this really have to do with the HIV response? And I would urge you to remember that of all the numbers, of all the graphs you're going to be seeing over the next few days, each of those numbers represents a person. And that is why we talk about human rights, because ultimately, the response to HIV is not about microbes, it's about people, it's about human beings. And it's about human beings who exist in human realities that come with social and cultural and economic dimensions. And we may have the best scientific techniques in the world, we may have all the funding we need, but ultimately the make or break of the HIV response is not at a collective level, it's not at a conference level, a laboratory level, it's ultimately at the individual level. It's ultimately about the individual decision to use a condom or not, or to get tested or not, or to adhere to treatment or not. But the problem with the state of epidemic today is that a lot of people do not have the ability to make this decision independently because of social, cultural, and legal frameworks that prevent them from having the freedom to make these choices. We've heard from other speakers about the challenges faced by drug users, by sexual minorities, by sex workers. These are groups that are so critical to our HIV response, and yet we still have so many countries that have laws in place that criminalize the choices that they make, which render them vulnerable to HIV. And yet at the same time, we hope to have universal access while we're ostracizing the very people that we most need to reach. There's a staggering irrationality in all of this, and it's not just a staggering irrationality, but it's a costly irrationality, because we're attempting to put out the epidemic with one hand, but on the other hand, we're fueling it by continually driving underground the very things that are fueling its growth. 57% of the incidence in the Eastern European region is thought to be due to drug use. That's a huge amount. Imagine how much we could decrease the HIV epidemic if we engage drug users and decriminalize these practices. MSM, men who have sex with men in the African region, most countries have criminalized this practice, and you've seen a lot of the news headlines about this over the past few months, I'm sure. And we expect to somehow contain the epidemic while consistently persecuting people whose rates of HIV are up to 10 times higher, not because this is inevitable, but because we choose to make it that way. There's a danger in the way that we're approaching HIV at the moment, and I think we do well to learn from a statement made by the head of the Stop TB partnership earlier this year, who said that TB is not a medical problem. It's an economic problem, it's a development problem, and it's a human rights situation. And the irony is that the HIV response was founded on human rights. The foundation of this response was rights. It was unprecedented in the history of public health to have so many countries galvanizing billions of dollars into a multilateral initiative like the Global Fund to respond to global health need. And this only happened because millions of people around the world mobilized around the right to health and around the right to life. But this is right now under threat. And unless we can go back to the roots of where this response came from, all of the gains, all of the progress that we've been hearing about, the decrease in prevalence among young people, the global decline in AIDS deaths for the first time in 2007, all of that will be undone unless we address the funding crisis that we face at the moment. And this is not the hysterical analysis of an activist. I challenge you all as media to ask every government representative who comes and sits here throughout the conference how much their country is planning to contribute to the Global Fund in the next upcoming replenishment in October. In Austria, the country in which this AIDS conference is being hosted, where 45 million euro is projected to be contributed to the Austrian GDP this year, the government just 3 weeks ago wrote to the Global Fund to emphasize that they shall not be making any contributions over the next 4 years because health is not a thematic priority of the development. At the same time, we speak about social development, economic development, millennium development goals. If we do not sustain investment in the HIV response, none of that will be realized. And if we continue to have false arguments like the treatment versus prevention argument when we know that it's the same, like HIV versus health systems, we will not make this progress. HIV is not overfunded, like we've heard from so many governments, such as the United States, who claim that they're diverting funding from treatment to address other neglected health needs. The challenge is not overfunding of HIV, the challenge is underfunding of HIV, of health in general. And health is not underfunded because we cannot afford it, it's underfunded because we do not prioritize it. In closing, I just want to draw attention to African states who 10 years ago made a commitment to spend 15% of the national budgets on health, and to date less than 10 countries have met this commitment. They'll be meeting in Kampala in a couple of weeks' time, and a few months ago our finance ministers decided that these spending targets just don't make sense and they should call for a review of them. So we cannot afford health in the African region apparently, but we can afford soccer, we can afford luxuries, we can afford wars, but we cannot afford the thing that is the critical foundation of all social and economic development. It's irrational and it's a scandalous human rights violation. If the Global Fund is not replenished in October, then we send a message to the world that health is an option depending on the price tag, and that does not make any sense for social and economic development of humanity. So in closing, I want to invite all of you to join activists who will be opening the AIDS conference at 5:30, and will be marching past the media room to demand that funding to the HIV response is sustained, that funding for global health overall is increased, because unless this happens, all the talk that you're going to hear over the next few days ultimately doesn't mean a thing.
Thank you, Paula. The third and final plenary will be on the state of the epidemic strategies for a cure. This is the topic of Dr. Sharon Lewin's presentation. She is the director of the infectious disease unit at the Alfred Hospital, professor of medicine at Monash University in Melbourne, and co-director of the Centre for Virology, Burnet Institute in Melbourne, Australia. She heads a research laboratory that aims to understand why HIV and hepatitis B viruses persist and evade the immune system, and trying to find mechanisms to deal with this problem. Sharon.
Thank you, Julio. There remains an urgent need to find a cure for HIV. This has been a major scientific problem and continues to be a major scientific problem. But we need a cure for HIV, because I don't think we should accept that HIV is a chronic illness requiring lifelong treatment with associated toxicities. And I don't think we should accept that anyone should be denied access to lifelong treatment, but that threat remains with us. Over the past few years, we've made quite a few advances in understanding what the major barriers are to curing HIV. and they include the persistence of HIV in parts of the body which antiretroviral therapy can't access. So we need far more research to understand exactly where the virus hides, how to flush the virus out of those persisting reservoirs, and develop a potential strategy to cure. Although we need good science, we won't get there with science alone. I really believe that this challenge needs to be embraced by scientists, clinicians, pharmaceutical companies and funders. We won't get there with just science alone. In closing, I'd like to say that there are already a number of potential strategies that look very promising, and I would argue that we need to move quickly into clinical trials to test some of those strategies. Finally, a cure for HIV will potentially shorten the duration that a person must take antiretroviral therapy. It's never going to completely replace the role of antiretroviral therapy, so universal access still remains a major priority. Thank you.
Thank you, Sharon. I would like to open the floor now for questions. We're going to take 10 minutes of questions. I ask that the person asking the question introduce himself or herself, and that the panelists try to be brief and show the questions. First question. Please indicate who you are asking the question to as well.
Thank you. Richard Ingham from the French news agency, AFP. Professor Montaner, I'd like to ask you a question about political presence at the conference here. We have the South African Deputy President here, who is clearly a step up in terms of political commitment from South Africa compared with previous conferences when, of course, we had more contentious figures here. I'd like you to comment on that. I'd also like you to comment on the presence or absence of leaders from Russia and Ukraine. If it's true that this is supposed to be one of the focuses of the conference there, why do we not have major political presence from these countries at this conference? Thank you.
That's not an easy question to answer in a sentence or two, but let me say first that we are delighted with the intervention of the Deputy President of South Africa. He was at a meeting earlier today that we shared the floor with Michel Sidibe, the Executive Director of UNAIDS, and I think that Michel said it very well when he emphasized at the end of the meeting that it was the first time in over 10 years that a representative of South Africa stood up, a high-level political representative of South Africa stood up at an international AIDS conference, and he actually received an outstanding ovation. That basically tells us that South Africa has now, following the Cape Town conference, made a very clear commitment to embrace the most progressive guidelines put forward by the WHO, which we fully support, and in doing so, is trying to make a commitment to do the right thing to deal with the epidemic. On the contrary, the leadership of some of the Eastern European countries most affected, and some of my colleagues here are better qualified than me to tell you about it, have shown total indifference to our plea. And obviously, we count on all of you to remind them that not being here is actually being heard loud and clear as a sign of being irresponsible to the point of criminal negligence. So you can call me there if you want. Having said that, I'm not going to let off the hook people like Stephen Harper, my own Prime Minister, because I dislike profoundly being critical of others without addressing my own domestic issues. Stephen Harper was invited to be a plenary speaker at this conference, and he has turned us down. And as a chair of the G8, the last G8, I am ashamed to tell you he's not here because he's afraid to confront the deficit that the G8 left on the table. And that, I hope that you will tell him I said so. Next question. There.
Flávio César, Brazilian Network of Sex Workers. Mr. Eve has mentioned this important issue of marginalization of key populations. Amongst them, sex workers are maybe the only ones who are forced to compulsory testing, which sounds like a marginalization within marginalization. In many countries and cities, including Vienna, what do you think that could be done in relation to that?
The WHO position on this point is very clear. There is no rationale for forcing people to test and there is no reasons for any population, being sex worker or being any other, to be forced to be tested. Of course, we should reduce the number of people who are unaware of their HIV status, because to be aware of HIV status is a door open for prevention and treatment services, but in no way we need to force people to be tested.
One more question.
Yes, Liz Heiligman from AIDS Map, and I have a question for Dr. Lewin. Can you give us in just a very brief couple words what you think are the most promising approaches towards a potential cure?
The current approaches are to turn off any residual replication that heart hasn't extinguished, optimise the timing of treatment. Early treatment is, there's evidence that early treatment will reduce the residual amount of HIV. And finally, flushing out the virus from these resting stable cells. And there are a number of potential strategies in which we can do that, either by activating those cells or turning HIV genes on. And we now have access to treatments such as IL-7 and a class of drugs called histone deacetylase inhibitors that look extremely promising in vitro. Both of those drugs have been used in vivo in patients and are safe and well tolerated. And I think we should really move forward to clinical trials to see if this strategy of eliminating these resting cells is going to be feasible. Finally, there are some far more experimental approaches, such as making cells resistant to HIV to mimic the outstanding case that was reported last year of cure in a patient from Germany who received a transplantation from a donor whose cells were resistant to HIV. And there are strategies to model this in patients now using gene therapy. Of course, highly experimental, very high-tech, very expensive, but a proof of principle that could potentially be simplified in the future.
I'm going to take one final question.
Hi, Jeff Berry, Positively Aware Magazine. This question is for Paula, and I won't try to pronounce your last name. But given that human rights seems even a more daunting task to solve that problem than HIV, what do you think would be some of the most important things that you would think that activists need to pursue?
Well, I mean, firstly, I would want to say that the human rights versus HIV tension is really a bit of a false dichotomy. You know, human rights are an integral part of the HIV response. But as far as what the priorities would be, I think if there are a few of them, firstly, the removal of punitive laws that target most at-risk populations, sex workers, drug users, sexual minorities. As long as those laws are in place, we are effectively precluding these people from receiving HIV services. So that's a critical step. Secondly, adopting an approach to testing and treatment that recognizes people's agency and the need for them to get tested voluntarily to understand why they need to start treatment, not to be stigmatized by healthcare workers because of personal choices that they make. Because the issue of stigma is one that we talk about a lot, but still don't seem to have gotten our heads around. And it's one of the things that repeatedly, when you try to find out why people don't get tested, why people don't adhere to treatment, stigma is often listed as one of the top reasons why. So I think those would be two of the most important.
I'll take one final short question, and that would be the final for this panel.
All right, thank you. Leonardo Bastida from Letra S, Mexico. Dr. Montaner, I would like to know that, well, you have been talking about prevention. However, for example, in all my region, Latin America, all the resources are given to the buying of medicines, and prevention is not considered on AIDS resources. How can we change, or how do you think with this conference can change the mentality of our governments to change the destination of the resources against AIDS?
There is a fundamental mistake pretending that any single tool is going to be effective on controlling the spread of HIV. And while I may be particularly an expert, let's say, in treatment as prevention, I make an effort every time that I discuss that into emphasizing the fact that we need a cocktail approach to the whole thing. And that includes other issues, everything that you hear around this table. Let me be very clear. I could have a fantastic treatment. It could be 100% effective at preventing everything, progression of the disease and HIV transmission and everything you want. But if I don't address the human right deficit that Paul is talking about, and I criminalize, prosecute, and stigmatize people with HIV, either affected, infected, or at risk, then I will be 100% ineffective, no matter how effective my treatment is. So our leaders need to understand that if we're going to make this work, they need to address the whole combination prevention approach, which includes the human rights. And that's why this conference has as a theme the human rights issue. And even more important, if we're going to make treatment efficient, which is another key word that will emerge from this conference, we need to get more bang for our buck. And in order to do that, the best thing that we can do is remove the human right barriers that make it so expensive, difficult, and cumbersome to get people that need treatment or testing or support to access those services. On that note, I'd like to thank you, thank the panel, and we'll move on to the next panel. I invite the panelists to hang around until the conclusion of the next segment so that they can make themselves available to the press as we go. Please.